Hello everyone, in this video we'll be discussing a mnemonic to help us remember the clinical features of invasive aspergillosis, and we will also be doing a question after the mnemonic. So the mnemonic is: he aspires to be at the gala, but he is feeling feverish and out of breath, coughing up blood. So here's this guy, he wants to be at the gala, but he is feeling feverish and out of breath, and he's also coughing up some blood. So the aspire part is to help us remember aspergillosis. The gala is to help us remember that these patients are going to be positive for galactomannan antigen. They're also going to present with fever, shortness of breath, as well as hemoptysis. And one important thing to note is that immunosuppression and pre-existing lung disease are going to be important risk factors for aspergillosis. So usually in question stems, you will get a patient who is immunocompromised or they have a pre-existing lung disease like COPD or emphysema. So now let's do a question to help us reinforce the concept. A 69-year-old man with metastatic colon cancer and a history of emphysema presents with 5 days of productive cough with blood streaks, fever, chills, and shortness of breath. He recently received chemotherapy. Labs show leukopenia, positive galactomannan antigen, and oxygen saturation of 83% on room air. What is the most appropriate initial pharmacotherapy? So with this question, so the patient has the presence of the galactomannan antigen, and there are also other signs of invasive aspergillosis, like the fact that he is coughing up blood, having shortness of breath, as well as having a fever. Also, the fact that he is immunocompromised, his white blood cell count is only 700, most likely due to bone marrow suppression by 5-FU. He also has a pre-existing lung disease and emphysema, so he has all these important risk factors for aspergillosis. And so the answer is going to be answer source G, which is voriconazole. Intravenous voriconazole is going to be the drug of choice for the treatment of invasive aspergillosis. And the treatment should be initiated empirically if we suspect invasive aspergillosis, because this fungal infection has a very high mortality rate. And we can confirm the diagnosis by doing a bronchoalveolar lavage or a biopsy with a histopathological identification of septate hyphae branching at 45 degrees. We can also do liposomal amphotericin B if the patient has hepatic dysfunction or hypersensitivity to voriconazole.